session here is the community care team model, and it is one of 6 sessions that is within the integrated delivery network training track. Don't want to chat about it much, we don't have a lot of time. You'll learn about it over the next 2 days. But basically there are 7 integrated delivery networks, IDNs across the state, working on the district project, Delivery System Reform Incentive Payment Program. And this particular session here, we'll chat more about it, but there's 4 goals of the district project. And it's basically working to integrate behavioral health and primary care. So, decreased care transitions, increased workforce, and 50% of Medicaid payments transition to an alternative payment model by 2020. So I would like to take this time to introduce to you Tory Jennison. And Tory's going to speak about herself a little bit, I think, as well. But Tory works for the Region 6 IDN, which is the Seacoast region. She serves as the Director of Population Health and a Stratford County Medical Reserve Corps Insert Director. Tory, you want me to you want to just chat about yourself? Okay. We also, some of you might have seen that Kevin Irwin was going to be presenting this morning, and we have a replacement for Kevin. And so this is Sandra. Sandra, I will also ask, instead of me reading this, I think it'd be much more lively coming directly from them to give a brief update. Lastly, this is a recorded session, so we are trying, many of our folks within the IDN are not able to join us today, so we opted to record this session. And so if you could just work with us to minimize noise as much as possible, especially in this corner because the microphone is behind you. We're going to be working to put this into a webinar at the end, so information will be forthcoming about that as well. So thank you very much.
Good morning, everyone.
Good morning.
That sounds like coffee, and it sounds great. Glad to see everybody on a Monday morning. My name is Tory Jennison. I'll introduce myself, and I'll ask Sandi to tell you a little bit about herself so you know where we're coming from when we share our community care team kind of adventure with you. I am a nurse by training. My background is all the things nurses do: acute care, home care, primary care, some emergency management stuff, where I started to get the sense, you know what, there are people who know how to make things happen faster and more efficiently than we do in home care, in health care, in hospital care. Because when you are in an emergency, when you don't have time to PDSA it. You don't have time to pull a committee together for it. So a good chunk of how we're going to talk about what we've done and what we've built is informed by some other disciplines, and I think that's kind of a neat approach. So my role with the Integrated Delivery Network, I've been there for 2 years now, is in population health. That means kind of everything nobody else wants to do. So it means technology, it means some systems thinking, it means what is a population, who are our clients, who are our communities, what do we know about them. Prior to that, I worked as the Continuum of Care Coordinator for the Seacoast Public Health Network and have done behavioral and psych nursing as well. So I'd also like to introduce, certainly not a replacement for Kevin Irwin, there's no replacing Kevin. Sandi stands on her own 2 feet as our new Director of Care Coordination for the Region 6 IDN.
Sure. Good morning, everybody. Hi. It is a pretty full group. Can everybody hear in the back? Okay, good. So we have a microphone, but neither of us wants to use it, so just give us a signal if we're not loud enough, and we're happy to speak up a bit. So again, my name is Sandra, or Sandi, Denoncour. I'll answer to either one. I'm also a nurse, but nursing was not my first career. My first career was in nonprofit community-based social service agencies, and I've been involved with nonprofit work for about 25 years. So working with homeless populations, people at risk of homelessness, folks that are transitioning from hospitals, families who are resource challenged, to say the least, who are having new children in all sorts of different areas. I chose to go back to nursing school so that I could start having these types of conversations, which is how do we integrate people and the whole person into healthcare systems, and how can I be a part of that and help in that. So my last 10 years have been as a nurse and practice manager at federally qualified healthcare centers, specifically Goodwin Community Health and Lamprey Healthcare over in the Seacoast and Stratford County. But I want to give Tory more credit than she gave herself for being Director of Population Health, which in my mind, when I know Tory and work with her, means nobody is left out, which is one of the considerations that I really appreciate about the work of IDNs, is that this is a perspective to say, how do we not leave anybody out of our care systems, of our thinking, of our care coordination models. And so Tory's been really essential in building that engagement in our area, so I'll give her more credit than she gave herself there. But thank you.
Thanks, Sandy.
My goal is to manage expectations. So that's probably all we're really going to say about the IDN, because I know there are some IDN faces in here, and we're going to call on them to kind of validate some of our statements and assumptions, but care coordination, systems of care coordination are not unique to the IDN. They're not, the IDN is not the only entity working towards this, so that's one of the guiding philosophies for our conversation today, is that this is not an IDN-centric conversation. If you have questions or comments or thoughts or want more information about the IDNs, we're happy to share it with you, but you won't get it in the next 70 minutes. So I just want to do an astronomy, astrology check-in with folks to make sure you're in the right place, so that you don't think you're getting what you're not. We are going to talk about our community care team process, how it got started. We're going to talk about what it is, how to get one off the ground, how to keep growing it. We're also going to talk a little bit about the value of a community care team, because one of the things that is really critical to be able to do when you're talking about starting anything new, especially if it requires a human resource investment, is what's the value? Why does this matter, and what are we getting for this investment? So hopefully when you leave here today, you will be able to say a little bit about those pieces, and even if you can't, you'll know where to go to ask. So that's almost just as important. So the other thing that I want to, because this is a behavioral health summit, there are going to be, at least in this room, some provocative statements. There are going to be some challenges to think, challenges to the status quo. So I would encourage you to listen in the spirit of that and let it kick around for a little bit. So, that one of the first times we talked through this starting slide, there was a collective in the room. But I think you need to sit with it for a minute and think about what we're really saying. A group of motivated people can change the world. In fact, it's the only thing that ever does. So that is another guiding philosophy here. It was a group of motivated people who changed this world into today, where we have a much safer place for an entire population. That world change came when a good portion of the world thought that what was going on was still okay and acceptable. We're going to talk about how do you challenge those really big systems thinking places when folks don't necessarily agree that anything is wrong. So one of the first ways we do that is talk about why care coordination matters. Well, first and foremost, care coordination matters because we've made a really complex system of healthcare, or systems of healthcare. It's really hard to navigate. We have created a position to help people get through the healthcare systems. Anybody work with navigators, care navigators? You know where else we put care navigators? On the rides at Disney World. You get navigators. Like, we don't trust that you can get through this forest on this boat without help. We built this, and we gave you a guide. We have built a healthcare system that requires a guide to get your healthcare, to be well. So this is a slide that talks about why we are looking at care coordination in Medicare. Because this is, even though the IDN project is oriented towards Medicaid clients, anybody who's spent 10 minutes in the Medicaid world knows how goes Medicare, goes Medicaid. So it is important to look at what's going on in the Medicare world. What are the creators and the designers and the builders of Medicare finance and systems of care thinking? Because they are signaling attitudes and perspectives that will, in many cases, inform the Medicaid process, even though it's at the state level and can look a little different and have different flavors. So we know that there are folks, 1 in 5 folks who have Medicare are hospitalized. readmitted within 30 days of a discharge. That's expensive. We know that 75% of those readmissions could have been prevented if we'd done a better job of getting organized. Not if the client had done something differently, if we had done something differently. We are a collective we. We are the folks who aren't the client. And that's going to be another one of the guiding philosophies that we talk about today. We're not talking about what the clients and patients I'll use interchangeably on purpose. We're not talking about what the client can do differently or what the patient can do differently. We're talking about what can we do differently. 1 in 5 who are admitted and discharged are readmitted within 30 days. 75% of those didn't need to be. That's a huge burden on our healthcare system, huge. We don't have great numbers, comparably for Medicaid, because states manage and collect their own Medicaid information. Nothing else that we can say about that. So we have uncoordinated care. That means systems are not in alignment. It means somebody's admitted, somebody's discharged, somebody's cared for in the community, and all of those ways of caring for someone are kind of missing each other in the night. When that happens, everything is just not working well. It's all the things you would think of. It's more expensive, less effective, it takes longer. Some of the things that I think are really important to recognize, but we don't value and we don't measure real well, is that clients get confused. I don't know where I'm supposed to go. I don't know who I'm supposed to call. Clients get aggravated. When they get aggravated, then they disengage. When they disengage, they stop doing their health-seeking stuff. That's on us. That is absolutely on us. How many folks in this room have had an unsatisfactory experience or encounter with a healthcare provider? And you people do this for a living. You do it for a living. How many folks who had that unsatisfactory experience said, I'm not going back there, I'm not doing that again? There you go, and you do it for a living. And you have resources, and you have means, and you have knowledge. And I imagine if we asked that same thing to folks who did not have means, resources, or knowledge, everybody's hand in the room would go up. So that client confusion, that client aggravation makes our jobs harder. Makes our jobs much harder, especially when you're a frontline service provider. That's why we're talking about how do we get these systems more coordinated? How do we get them into alignment? So teamwork, right? Community care teams, teamwork. But what happens when the teamwork doesn't get the outcome that you are expecting? What happens? Why does teamwork not always get us faster to a solution? Might be because we don't all have hard hats, but there are other reasons why. Yes, Ms. Patty.
That you're not addressing the core problem.
Not addressing the core problem, exactly so. Other reasons why we might have a team that doesn't get us the expected outcome. Yes, ma'am.
Some of the team members might have their own agendas.
They do, absolutely. Other team members have a conflict of interest as well. You have agendas, and then sometimes those agendas are in conflict. And those are always hard to know. Well, some are not always hard to know. Sometimes they're hard to know. What else? Different agendas, conflict of interest.
Lack of communication.
Lack of communication is huge. Absolutely huge. So,
How about funding? Some of those team members might be getting paid by different people. They
Yep.
might be competing for
that
the same
gets,
funds.
exactly. So, you never know. Folks have different motivations. Teamwork doesn't always get the job done better because it's funny to think that everyone has the same goal. That's Congress. That's a pretty current events kind of example. They're a team, right? Their uniforms all look the same. They're a team. Do they have the same goals? They don't have the same goals for all these reasons. Conflict of interest, different funding sources that are supporting them. Sometimes philosophically, they will be very clear. We don't have the same goals. So it would be naive of us to think that we're going to get alignment by doing nothing when we know these things to be true. And I just gave myself an early holiday present in the form of 2 new tires and 2 new wheel bearings. So I think of alignment because I kept saying, we're going to have to do an alignment on your, okay, I'm pulling together a presentation on alignment. I want to talk with my mechanic about what his idea of alignment is. Maybe I can learn something here. And I actually think I did. He said, when you have something out of alignment, I had a wheel bearing that was bad, so it made the wheel turn out a little bit the wrong way. So I had a right wheel that was going in one direction, and the left wheel was going in another direction. They were not in alignment. So the right wheel started to wear badly. Steel belt kind of, what's wrong with you? You're going to crash badly. So they needed to put new wheel bearings in, they needed to put new tires in, and then they needed to align it. Like, wait a minute, you can't just put the right stuff back in and it all comes back into, what? We don't have a mechanism in healthcare to knock things back into alignment. We can add benefits, we can add providers, we can add workforce. We don't have a mechanism to get them all back in this, aiming everything structurally in the same direction. I didn't sleep that night. That was not good. Like, we need more mechanics in healthcare. So why doesn't everyone have the same goal? So we've talked about some of the big systems things, and we've identified that not everybody has the same perspective, not everybody has the same line. Hopefully everybody in this room has seen this slide. I hope you have. It's been out since like 1997. It's probably a newer version, but this one isn't it. Tells us really that 10% of healthcare providers, things we bill for, actually has an impact on someone's health outcomes. 90% of health outcomes are impacted by other things that aren't those things we pay for. So there's a little math dissonance there. Like, we pay for stuff that impacts 10% of the outcomes. That's a different conversation, but keep that in the back of your head. So social determinants, all these things that healthcare is only this one, right here. We've got education, transportation, environment, housing, food security, discrimination, stress and trauma, income and employment, neighborhood health and community environment, healthcare. 10%. So when we talk about how as healthcare providers we have all of these different reasons why we are not in alignment, then we get to go talk about what happens once you add all of these folks in, who get paid or don't get paid, who have different philosophies about the services they provide, who have different access to clients and each other. You start to think, oh my God, what a mess, I'm gonna go be a mechanic. So, clients get it, but they still think we can help them as healthcare providers. They still think that we need to help them some more. So this continues to amaze me, this idea that almost 90% of folks will say, I think my healthcare provider can give me information about lifestyle habits that could impact my health. Over 85% say, I think I can rely on my healthcare provider to have a conversation with me about my mental health history. You guys, we get down like, oh my gosh, this is such a mess, we're not doing a very good job, but sometimes our clients, they still have faith in us. So there's still time. There's still time, and I think that's an important thing to take away, that we can work harder and faster at this because they are really, really expecting us to. They're still believing in us, in our ability to come together as a team. So when we talk about social determinants of health, it's another way of looking at it. This is that circular model in lines for folks that think that way. So everybody feels embraced here today. Our community care team is a tool. It's just a tool to bring these different sectors and perspectives together, which sounds an awful lot like alignment. This is a tool. This community care team is one way that we can think about doing what the mechanic does. When you put your wheels into alignment, it's almost an orthopedic procedure. It's hydraulics and it's steel tools and it's lots of force. We would probably all be a little uncomfortable if we brought that as a toolkit to the table for caring for humans, but the community care team serves the same purpose. It's one tool that we would like to encourage you to think about using as a mechanism to bring perspectives into alignment in your practice. So one of the things that I think is really important to talk about is that why care coordination? Why not table of magical thinking? No, really, they both make people feel better when you say them, but what do they really mean? We've had a conversation in the integrated delivery network world for 2 years. Care coordination, case management, case coordination, care management. What's the difference? Does anybody have a great way to explain the differences to us? Yeah, me neither. So we have to start talking about that, because if I'm telling you that a community care team that helps you deliver care coordination is a tool to bring your systems into alignment, I have to have some confidence that my definition of care coordination is valid and reliable. So Medicaid is one way of thinking through definitions, because if the federal government does one thing really well, it's create paper with lots of words. And that is one place we can go to say, how is it defined? How is it defined at the federal level? And it's not, I'll save you the trouble and hours of looking, it's not well defined, the difference between care coordination and case management. At a very macro level, case management is reimbursed, care coordination is not. That's, if you have to talk about your bottom line and macro level, they're not usually considered the same thing, but in this case they are. But they are very similar themes between care coordination and case management. So I just want to talk through those a little bit, because if you think about starting a community care team, these are the conversations that are going to come up. They're going to come up when you're talking about the value. They're going to come up when other folks who provide case management say, wait a minute, that's what we do. So here's hopefully a little bit of information that can help you navigate those discussions. They all are comprehensive. This is coming out of Medicaid CMS definitions. And one of the things here is that all the services a client receives are to be coordinated. I'm going to come back at you with a provocative bit again. I don't know that I agree with that all things need to be coordinated. And we'll talk a little bit about that in our experience with our community care team. Lots of folks do their jobs really, really well. Not everyone's job rises to a level of importance that we all need to be paying attention to it and considering it against some of the big gaps and vulnerabilities and risk. So that's a CMS definition. I would encourage you to think through your environment, your community, as to whether or not you need to follow it to the letter. They need to be patient-centered. That's pretty straightforward. And they need to have follow-up capacity. Folks need to be able to be served regardless of their population, and there needs to be follow-up. Did what you did work? So those are ingredients for a recipe that looks awful. Awful. Looks just awful. I have a 15-year-old daughter. I've seen that in my kitchen. So it looks hard. You can do all this, and you can put it all on the table in the pot, and that's what you get. So a community care team that you actually come at with a little bit of intention in the design process can be one way to avoid that sort of mess. So there are some pretty essential elements of care coordination that Medicaid identifies, and I did ask Sandi to walk through, kind of give you a breather from me. This is all of us. We're juggling all these things, and we have tiny little arms. It's not enough to juggle it. You have to have tiny arms. But we all wear great hats, because style is everything when you have tiny arms and you're juggling everything. But we want to kind of talk about what does it mean. We don't really know the difference between care coordination and case management. Is it a little bit like some other stuff where you know it when you see it? And we kind of get your thoughts about that.
Great, thanks. So I know it's hard for you in your handout to read this list because it's about this big on your piece of paper. So hopefully you can see it up here. And one of the points that Tory was making that I want to emphasize is that everybody has a lot of different language for how we talk about care management, care coordination, service providers, what does that mean? For direct care service provider, for community service provider, what does it all mean? We all have different language that we use around it. So one of the things that we challenge folks to try to think about is just getting to some common language. So whether that's inside your own organizations, the people you sit next to every day, or it's the people you collaborate with outside of your organizations, it's really important to understand that you're using the same language, that you're talking about the same thing. So when it comes to putting the rubber to the road and who's going to do what for a patient or a client, you're talking about the same things. So it is really important. But let me just, we'll take a little bit of a breather from slide clicking and just see who we have in the room. So I'm just wondering how many people in the room are direct service healthcare providers, so clinicians providing direct care. Okay, great. And how many people are in support of direct care at either a doctor's office, a community health care center, a community health center, behavioral health center, in support of direct care services in the office? Okay. And how many of you are involved in the community services? So more social service support? Okay, so we've got a little bit of everybody. Who has all of that where you work? Who has all of that under one roof? Anybody? Couple, right? So the exceptions are the people who have a good majority of what a client, a patient might need in one place. So most of us have to go out and get it. We have to bring it together. We have to find who to talk to about it. And that's a challenge. So on this list, it asks you to kind of think about what you personally do quite a bit and what you may do very rarely. So I want you to just take a look at it and put a couple at the top in your head of what you do fairly frequently and a couple at the bottom. You say, I don't do this at all. I'm not that person. When you need this, don't ask me. And I'm just asking, when you look at this list, is that easy to do for you? No. It's fairly difficult for some people to do. Do you think it has anything to do by, you might want me to tell you, what do you mean by medication management? What do you mean by community outreach? So some of the definitions beneath here are what we make of it, right? What do we call what we do? All right. So one of the things that we think about when we talk about bringing community care teams together is how do you put people at the table who have different strengths, so different types of access to different services for clients, and where are the gaps? So when you come to a community care team table, it's important for you to know what you're bringing. What are your essential skills? What can your agency or you personally do for clients? But it's absolutely essential for you to know what you can't do, because that tells you who you need to invite. Who do you need to invite to that conversation, right? So how many of you have a directory, a Rolodex, a contact list in your email that's this long of people that you might call when you need something? Right? There's a long list. How long did it take you to put that list together?
Still working on it.
10 years, 15 years? Right. It is really hard. Networking, believe it or not, there are lots of us doing great work, but networking is hard work, right? And sometimes I remember from working at the homeless shelter with families particularly, is I would have a family come in, and every family, believe it or not, everybody in this room knows it, is completely different. So what they need that night is shelter. What they need tomorrow is different than the family next to them, and different than the family next to them. So what I was trying to do as a new wide-eyed person in human services was piece all that together without having met all the other people that are doing the work that I absolutely needed to talk to. So it became very much, who did I know? I just wish I knew somebody at the housing authority. I just wish I knew somebody at the doctor's office. I just wish I knew somebody that I could call and just have a conversation about a real person who needs something today, and how on earth do we get that done? So that's what community care teams are about, is saying, what can I bring to the table? What can I not? And making sure that everybody at the table can answer the questions about what everybody there is doing and what they can do for each other. And and then bringing some of our toughest shared cases or clients or patient stories to the table and talking them through and figuring out directly, person to person, how do we get this done. So we literally do that at a table. Literally do that at a table, which is hard to pull together. It's a time commitment, it's a community commitment, but the good news is that if you think really hard, you probably can think of in your own community 2 or 3 tables you're already at, or that folks that you know are doing good work are already at, to try to get at least one of those social determinants of health. And then the idea is, where do you build? How do you build? How do you connect, align, and build? So, thank you.
Now you feel like being a T-Rex with a sassy hat might not be so bad. And that's a good thing, because we have a lot of work to do. We asked, well, researchers in the journal Medicine asked about 375 folks, how coordinated is the care experience for your organization's patients between the inpatient setting, post-acute setting, and home environment? So this about reflects what we've seen in the room. 3 folks over here, fully coordinated. 1 agency, fully coordinated. 30% mostly coordinated, 53% somewhat, 10% not. So we're at 63% between somewhat and not. And that's of folks who even know what coordinated means. Like that's, how do you know when to stop? Is coordinated that I made the referral and somebody told me they got it? Or is coordinated my client got what they needed? So they can be very different conversations. And just for, in case anybody's paying attention in the back, care management is tucked in here. It's considered separate from all these other things. Separate but equal, separate but not equal. So we're no closer to a definition. And we've kind of gone through a couple different ways to look at this, a couple different ways to think about it. When in doubt, go to the Federal Bureau of Tree Killing and see what they say. When you don't get an answer there, then you look at who's paying for it, because sometimes you can tell who owns it and what their expectations are and substitute that for a definition based on who's paying for it. Who pays for care coordination? There are a couple CPT codes. Some folks use them, some folks don't. It depends on who the providers are, who the agencies are. You can get care coordination paid for through bundled payments, through per member per month arrangements. You can get them through grants. You can get them through 1115 waivers. Usually, you hope it's someone else paying for care coordination. The reality is, usually it's no one paying for the care coordination that you're doing. What happens if you have care coordination where it's paid for by all of these? So you have to coordinate the care coordination inside your own agency. Oh my gosh. That makes it sound like fun, right? Let's do more of that. Said no one, ever. So we don't know what the feds think the difference is between care coordination, case management, and all the little options in between. We don't really have a great standard set of definitions from the people who pay for it, kind of, sometimes, not always. Yeah. So then we're kind of left to our own devices. We're left to say, all right, well, what do we got? What can we do with this? Sometimes then we have to come at it from what is it not? If I can't tell you what it is, let's talk about what it's not. So then we're going to go a little bit deeper and say, well, let's talk about what we know it to be, even if we know what it is supposed to be isn't enough. Case management has a couple different giveaways. Some folks have done a great job of signaling this by calling the model that they're using in their care delivery yada yada management, which is different from yada yada coordination. We have a strategy. We have a strategy. We can go out and say, put all the things named coordination in one category and all the things named management in the other category, and ta-da, we're done. We're not done. Because those folks who named their model were just as confused as we are about what the differences are across and between folks, so and within. So there are a couple of standard things that we see. Collaborative. There's an assessment. There's a plan. There's implementation. There's evaluation. How many nurses are in the room? ADPI in nursing. Assess, diagnose, plan, implement, evaluate. Nurses do this. We do this from the day we get into our first clinical with our first naked hygiene. We do this. But you don't know that. If you're not a nurse, you don't know that nurses are trained to think this way. Well, if you learn nothing else today, you can say, I'm going to go find me a nurse, because they know how to think like this. And I can ask them for help doing things that are essential elements of case management. Assess, plan, implement, evaluate. Here's what I see, here's what I'm going to do about it, here's how I'll know if it worked, and here's what I do if it did or it didn't. Not rocket science. It's really not. I don't know how rocket scientists think, but I'm pretty sure this isn't it. So we have a bunch of different types of models that signal case management a little bit more purely. You can hire somebody to do some case management. You can do clinical case management in the hospital. You can say, you know what, we have some strengths-based case management, clinical resource management. That's insurance companies saying, are you using too much of our stuff? Are we paying for too much stuff for you? They're all assessments with plans that will be implemented and evaluated. They're all case management. So now we've got some other options for care coordination. These are not for you to remember, but only for you to notice that, oh my gosh, there's a lot. There's a lot of this stuff out there. PACE, Program of All-Inclusive Care for the Elderly. That's been in the news in New Hampshire lately as a model of care. Is it care coordination or case management? Might be good to think it through. The community hub model. A lot of mental health centers, a lot of children's behavioral health has had a model of care that is a hub type model. We've got community health workers who are fantastic new elements of the workforce, but there needs to be some more conversation about how folks are using them. Health homes, behavioral health homes, integrated health homes model. What do we not have here? The clues for coordination or management. You know, they don't make it easy. They don't tell us, is this supposed to be a coordination or a case management? So you kind of have to think about it, and how does it fit in your practice, your network, your community, your environment. And that's actually a good thing, because it really can be anything along that continuum of care coordination and case management, because those definitions aren't the essential pieces of what matter. This is the continuum of integrated care models and features, and it's just meant to make you do exactly what I'm seeing. That's crazy, it's ridiculous. Here are some care models. Fee-for-service, patient-centered medical home, accountable care organization, a comprehensive accountable care organization, which apparently makes this an incomprehensive accountable care. I don't know where we do this. Other integrated care models. Then we look at how are we measuring whether or not they're working. We collect data. We might use data to do a better job. We're pretty sure that we're using data to do a better job. How are we paying for it? Yep. More money for the service, less money if you do it well. Less money for the service, more money if you do it well. How do we know if it's working? We're not sure. Things look good, the MCOs tell us that we're doing okay. We actually can see improvements in our clients' health and wellness. Data sources vary, the complexity of the data sources vary, and then there's some other states that have some programs that look like some of the stuff up here. Where do the integrated delivery networks live? In theory, they live here. In theory. In practice, they are comprised of partner entities that live all along this continuum, which is why care coordination versus care management is not the most critical conversation to have, because the community care team is a tool that will work in any of them. So we have this incremental approach to shared care planning. If this is your first day hearing about a community care team model, it's all right. Probably you've already got some of this going on, an integrated core team. Primary care providers, behavioral health providers, care coordinators, they share under HIPAA, only HIPAA, in all the official HIPAA ways. They get written consent for Part 2, 42 CFR Part 2 stuff. This is happening right now. If this doesn't happen, nobody gets paid and you don't stay in business. So I promise that you've already got this model of care coordination happening, even if it's only two providers talking to each other, someone sending a discharge summary, someone reading a discharge summary. That counts. That's I'm aware of what you're doing. Then you've got a next stage of boundary crossing where, hey, Sandi, you work over there, I work over here, but you're my I know someone. I need to get this piece of information. I know someone there. That usually means if I call the main number that everybody else knows to call, I will get nowhere. So I know someone. Here's your I know someones. Here's your community care team. As you get more complex operationally, because it's harder to do, you don't need to plan a whole lot for two people to bump into each other and have a conversation in the hallway. Happens in the potty, happens at lunch, it happens. It's kind of organic. This happens with a little bit of intention, like, oh, I need this thing right now, I'm going to call somebody. This happens with a lot more intention. It takes more work, operationally, more logistics, more planning, but you get community supports and you have organizations that are going to have access to PHI. We're going to tell you how to do that. Don't panic. Don't say, oh, it'll never happen in my agency. PHI, HIPAA, We've navigated that. We get consent from all of the folks we talk about. There's no value in trying to help someone who doesn't want to be helped. We have yet to meet anyone who has said no thank you. Because we've created a system that's really hard to navigate. And we frame the script in the introduction as such as that. We've made a mess, but we're going to walk with you to help figure out how to get you what you need. Would that be something you're interested in? It's essentially the discussion that we have. And we do some consent tracking, because one of the things that's really important to folks when you sit at a table with people who aren't from your agency is that, are you allowed to talk to me? Are you allowed to talk to me? It's huge. So, and absolutely, my license is active, but I'm going to say this anyway. I might not be allowed to talk to you at the table, but we all know how to convey information not at the table. The goal is to get that information back to the table, where everyone can hear it, and not just the few people that you know, that you trust. So we have an integrated delivery network in Stratford County, in the Seacoast Public Health Networks. We are a kind of compact little area. This is where our community care team was born. It's 3 years old 2 weeks ago. It's kind of neat. Our integrated delivery network, as April said, one of 7. Goal is to do a better job of organizing the system of care for folks who have Medicaid between behavioral health and medical health. Our perspective in Region 6 is confounding to a lot of folks, because we think you do that by resourcing and developing the folks who are not behavioral health or clinical medical providers. Like, well, wait a minute. If you're trying to connect behavioral health and clinical medical folk better, why are you resourcing and developing folks who aren't them? Because 10% of health outcomes are affected by those people. So we have a community care team model. We have about 30,000 folks, attributed lives, which is a very not nice term for people. 30,000 people, 30,000 families, 30,000 friends, moms, dads, grandparents. We have a couple of key clinical partners. We have a couple of mental health centers. We have 1 regional substance use disorder provider. We have 3 FQHCs and 4 hospitals and their affiliated primary care practices. One of these hospitals is HCA Portsmouth, which is not a nonprofit hospital. That has a little bit of a twisty flavor to this. So the community care team started as they were funded by the United Way of Greater Seacoast. It was a team-based model that Kevin Irwin kind of proposed in his work with the Greater Seacoast Coalition to End Homelessness pre-IDNs. He has a background in housing development, and they said, hey, we're going to hire you to give us some advice and some recommendations. They had a couple of community forums. This idea that he had helped develop in Middlesex, Connecticut, around Middlesex Hospital to convene a team of folks to talk about how do we help those people who are homeless. Because right now, no one can serve people who are homeless because you need to have a home to be able to receive the services that everybody else is able to deliver. That was the goal. It was not a medical community care team. It was not even really a social service community care team beyond housing. If we can't get folks housed, we can't serve them, was the genesis. Handful of agencies. I think they started with 10 or 11. And Kevin's favorite phrase is, do it. Schedule a meeting, just do it. You can sit around and plan it for another 6, 9, 12, 18 months. Just do it. To Sandy's point, find a table. Find a table. Buy a table. We'll loan you a table. We will bring you a table. And you just say, on this date, we're going to get together and talk about a community care team. And Region 6 IDN will even bring the coffee. We will come. We'll show up with donuts and coffee. And we'll see what happens. Just see who shows up. So the biggest lifts to make that happen for us were not finding a table. It was creating a release of information that the early folk, those key clinical partners, can live with, because compliance is a really long, really dirty word for a lot of folks. And our goal was to not have to ask every client to sign 17 releases from our participating partners. So it took probably a year for the final holdout hospital to say, all right, we're comfortable with this release. Because it's not their release, it's a release we drafted that has everybody's agency on the back. It had to go through compliance in every agency. Once the hospitals did it, everybody else went, are they good? They're good. Well, if they're good, I guess we're good, and we don't have to pay $7,000 for an attorney consult. That's how you stay in business as a nonprofit. You pay attention to things like that. So we got the release of information done. The case presentations were a big lift. The goal was to share information, to share experiences about someone. So someone brings Tory's case to the table and says, yeah, this is what's going on with Tory. I'm really struggling. I don't know what to do next. There is a temptation, and we've all been part of that, to everybody goes, oh my God, I work with Tory. That's awful. She did this, and she did that, and she did this, and then she didn't do what I told her. And that picks up steam around the table. We've all been in those conversations where everybody knows Tory. Nobody necessarily, not everybody doesn't know what's going on with Tory, but they know what their experience with Tory was, and it wasn't great. There isn't conversation about what do we, early, because it wasn't medical and it wasn't clinical. And if the goal is to find folks housing and there is no housing to find for them, then what else are you going to talk about? You're like, we got housing options? Nope, okay, next. That was a challenge for folks. So the temptation is to try to talk about other things about the case, and without some good intention and facilitation, that can be not helpful. It can be not therapeutic. It can be kind of not be our best selves at that table. So one of the things we did maybe a year and a half after this got started, when the IDN came in and said, oh my gosh, great model. You've got so many partners at the table. Can we start to refine the discussion a little bit and facilitate the case presentation a little bit so that we can maybe get a little more kind of engagement from folks who historically don't touch only housing. And this really amazing thing happened. So this is something that I hope everybody is familiar with, that when we have folks in the hospital, you come to the hospital, everybody can see what's going on with your case. The provider admits you in the ED. The nurse takes care of your business in the ED bay on the computer. You get labs. You get a team maybe who's working together for orders. It's usually the ED provider, the hospitalist on the floor. You get a discharge plan put in place. You get maybe a social worker, or the nurse says when you leave you're going to do this, this, that, and the other thing, based on what the lab says and what the clinicians in the hospital say. And then you leave. You leave the hospital with your little white bag with your footy socks in it and your 9-page discharge summary that you signed, and somebody picks you up and you go home and somebody says, so what happened? You're like, I don't know. What are you supposed to do today? I don't know. I don't know. I don't know what I do now. And then you look in your 9-page discharge summary for what do I do now? And you realize, there's no part that says, here's what I do next. It's here's what they did for me, and it's here's what I should do if something really bad happens, but I'm missing the page that says, what do I do now? Who do I talk to? Who do I call? It isn't because folks don't do a great job managing your needs in an acute care environment. It's because there's no, or limited, there's just limited connection between the doors of the hospital and the doors of the place you need to go next. Because to Sandy's point, everybody needs to be someplace different. So this can work really well, and it does work really well. But when we have someone leaving the hospital, they go from being surrounded by a choreographed, really well-executed effort by people who work as a recognizable team. Everybody works for the hospital, or the hospital system. I know who you are, I know who your affiliation is, I believe that you're here to help me, so I'm gonna listen to you. Where's my last page that tells me what to do when I don't have you anymore? Because now I'm going out into the world. There's gonna be a whole bunch of people who kind of look like we're all on the same team, kind of. But the game has changed. The game has changed. There's no choreography here. There's no everybody knows what their role is once you leave this.
So one of the things I was going to jump in and say is that for a lot of folks, we talk about transitions and we think about transitions from inpatient settings to outpatient settings or to home. But what the IDN specifically is challenged to do is to work on systems that we know will have an impact on Medicaid populations. So with these very complicated social situations where it just isn't that easy. It's not that clean and it isn't that easy. So what happens when you're homeless and you're discharged from the hospital? So we have a couple of folks here who are part of a transitions team that's an essential piece of what we do to answer those questions about, your paper says you're supposed to go see Dr. Jones on Tuesday, which is 72 hours after your discharge for your hospital follow-up appointment because they're your primary care provider. Or you're supposed to have a follow-up with your psychiatrist in 3 or 4 days to make sure the meds they started you on are working for you. But you don't have a way to get there, you don't have a phone, you don't have all these other things. So what we started to really have to think about is widening that transitions view. So that framework from the hospital out into the community is to think about transitions from other places. So we talk about community care teams. We just want to let you know we're talking about bringing to the table transitions from facilities that you recognize, so hospitals, inpatient behavioral health units. It could be a lot of other places as well. So it could be community corrections, so people coming out of jail. How do they get reintegrated into their healthcare plan? What is their healthcare plan when they leave? What is their, if you have a substance use disorder and you're coming out of a structured environment where you have regular support, what does that look like when you get out? We talk about physical rehabs. If you're elderly and you don't have resources, what does that look like if you're leaving? And you may need to be thinking about long-term care in the future, those sorts of things. So we just want to encourage people to think about those transitional moments, all of those transitional moments, as the ultimate conversation for community care team. That's really what we're talking about, is where do we hit all of these roadblocks that are they're more than just hospital, your outpatient setting. And then to think about what other kinds of transitions you might see that go unsupported or unrecognized, because those are your opportunities at the table. That's what you want to talk about with the community care team.
So we don't know care coordination from case management. We do know that hospitals do a pretty good job of making sure that you don't get lost in the building. But now we've got you leaving the building, and we need a set of guiding principles that will help all the folks that are supposed to support your needs outside the hospital think through their role in that. We decided that we needed to have a common objective. We want to provide person-centered care and improve outcomes by developing wraparound services through multi-agency partnership and care planning, aka teamwork. Just more words, because it looks fancier. Important to note here is that care planning is not the client's care plan, it's the partner agency's care plan. We spend a lot of time talking about, is care plan a verb or a noun? If you're sharing care plans, does that just mean everybody brings theirs and passes it around? Here's is mine, I'm sharing. Like, okay, that's nice, you did a good job. Or is it a verb where we create it together? Do we start from nothing and create it together? So, I'll give you a spoiler. We did the latter. We did the latter. It's a core belief that community collaboration is necessary. We're back to that 90% of stuff that happens that impacts health outcomes does not happen in one provider's office. And we have a core understanding that the work we're doing matters. Because there is no, these are complex systems. When we talk about systems integration, we might as well put complex in front of them. Not everybody you see, not all of these 30,000 people are going to need to come in front of the community care team, their case in front of the community care team. You know, the community care team is the place where those folks are living lives that have such challenging and complex combinations of risk and vulnerability that we can't figure it out on our own. At our partner site level, at our agency level, in conversations that we know how to have with a couple of us, that we need the hive mind, essentially. We need to do some brainstorming. So when folks come to the community care team table, we have a couple of cases. You'll see we've got 50 plus agencies represented in our community care team list. They do not all work with everybody that's being referred. Some of those folks, some of those agencies have never worked in the time I've been working with this community care team. Their names don't come up at those referrals, but they keep coming. And they don't keep coming because they don't have something better to do at 9 o'clock on a Monday morning. They keep coming because the other thing that happens in community care team, you learn who your network is. You learn what your colleagues and your partner agencies do and don't do. You know, Kevin puts it really well. He says, you know, it's a way to, you know, we've had these conversations at the table where it's like, I thought that was your job. We don't do that. And everybody around the table goes, you don't? We've thought for a decade that you did that. You're like, no, we've never done that. So that's really critical learning space. So that you stop referring folks to somebody who doesn't do what you're referring them to. But also so that when you go back to your home agency, your ability to manage complexity is better than it was prior to 9 o'clock on Monday morning. The amount of complexity you're able to manage increases in your home agency because you say, I know how to fix this. I know who to call. I know who to talk to. I know who does that. So that client that you may have brought to community care team in April, by the time August, September rolls around, you know how to help them without bringing them to community care team based on what you've learned at community care team. So, yeah. So we've got this awareness that I think this theme, we have to figure out how to improve the way we communicate with each other. And this is a pretty good example of what happens when that communication is not clear. We've all been there, right? Right. So today, where's our community care team? We convened a handful of folks. We found a table. We did a release of information that the compliance offices could live with. We crafted a process where partner agencies introduce the release of information to someone that they want to talk about, and they get that client's permission. It's not done from a central place. If I'm concerned about a client, I have that conversation with a client. I have them sign the release of information. We do have a staff person who gets those consents and who gets the case summaries, and we'll look at that document. And 4 or 5 days before the meeting, sends them out via secure email to the community care team. That's our process. It's not complicated. So the expectation is that folks will get those referrals ahead of the meeting, and if it's at all possible, they will query their own systems to see if they've had contact with that person. Sometimes that means, have we worked with them? Have we worked with them? That's querying their system sounds fancy and high tech, and usually it's not. Usually it's yeah, let's check to see if they have a record in our EHR, and then let's go find the people who may have worked with them. So in the last 36 months, we have worked with 237 individuals. This is kind of artificially inflated because 60 of the folks that are in this count came from the January emergency warming shelter that we opened in Rochester during a really prolonged cold snap. So yeah, we've continued to work with them. 58% are Medicaid beneficiaries, 29% are Medicare beneficiaries. There are some dual eligibles in there. 63% had a PCP when they were referred to the community care team, and by had a PCP, I mean the MCO had a name on a card. That's very different from, yes, I have a doctor and I know who they are and I've been to the office and we have ever had an exchange of communication. 51% are homeless. Another 15% are unstably housed. They're couch surfing, they're in motels, they're in a shelter environment. This is low. 54% have a diagnosed or suspected mental health condition because we didn't start tracking this from the very beginning. If we go back to when we started tracking consistently, we're at about 85–90%. Same with this number, 45% with a diagnosed or suspected substance use disorder, and definitely some co-occurring in here. 52% are engaged with one or more organizations. So now we have this great release of information and the confidentiality agreement. That's what we ask everybody who participates around the table to sign. It basically says, here's your role as a professional and as an advocate and as someone who knows that what we talk about here is for the benefit of the client and it stays here. That also means, because we went through the process of having this discussion, that we don't have corrections or law enforcement at the table. Other folks may make different decisions. Call us. We'll tell you what we think about that. Because, well, there are case managers and care coordinators in community corrections environments. They have a different set of expectations. If they have knowledge of or awareness of risk behavior, it has bigger implications. There, see, I told you anyway. If you can't figure out how we feel about that. So we do have folks who come visit. We invite anybody who wants to see a community care team in action to let us know. We meet in Rochester on the first and third Mondays and in Portsmouth on the second Monday. We've done some improvements in our process. Get some tighter meeting facilitation. We're building a shared care plan. We have a case template. And we're starting a new team in the Exeter-Hampton area. And that came out of folks who were attending the Portsmouth team going, we actually think that our geography and our network is a little bit more defined. So here's how we do it. We have a case presentation template. We ask folks who are sending it along to us, making a referral, give it their best shot. Put as much as you know in here. We do not have eligibility criteria. Some folks do. The eligibility criteria for our community care team is I'm stuck. It's a partner agency who says I'm stuck. Sometimes when we get these, we'll call them up and say, I think I have a way to unstick you that doesn't involve bringing this case in front of the whole table. That's been a process improvement. Here's who we do it with. Here are all our community care team members. There's a little bit of everybody on there. We're happy to share the confidentiality agreement with folks, the release of information document with folks. So here's a quick example, and when you see the slides online, you'll be able to see a little bit more clearly. This is what we use to track our work, because what happens when everybody agrees, you know, we bring Tory's case, Tory's stuck, Tory needs an ID, Tory needs to go to a PCP office. Tory's got 5 people willing to help her, but they're all stuck in the doorway. It's Keystone Cops. We don't know who goes first. And that's what happens at the table. You guys go first. You need to get the ID. Without the ID, this won't happen. Then once the ID happens, you're going to call. That's all that happens. It's not magic. There's no, well, let's create some housing because this person needs it. Yeah, this was a client who is co-occurring with developmental disability and behavioral health and medical health needs. And they're just stuck. They were transitioning from youth services to adult services, and the service milieus are very different, the products are very different, and we just needed some level setting about, well, once they leave the school environment, where do they go? What comes next? How do we talk about it? What's the decision analysis process? And who's helping? Who's on this? Who's looking at financial eligibility and family support? Where's the IDN team? Who's working with this kiddo at the Northeast Rehab? It's just kind of a snapshot of situational awareness. And our next steps that came out of a meeting, we're going to request some assessments and services for short-term in-home supports from the doctor's office. Because you got to do that. When you are going to the school setting and you get your PT and OT embedded in the school, Who's in charge of asking the doctor's office for the orders? Well, the parents certainly can, but they don't know what to ask because they don't understand perhaps what was going on in the school. They need the recommendations from the school therapy team. Who's helping that happen? It's just that sort of process about where do we go next. We have a shared care plan record that's coming up for us. All the IDNs are building something out. It's pretty spiffy. Important elements for us are being able to track the consent date. How long can we keep talking about this person? We're able to track the who's on the team. It's one of the really important things that we do is who's been in contact with this person. We can track any financial information. We can track assessments. We have our care transitions folk who are doing their critical time intervention assessments. If we do any other sort of assessment, we can save it here. We can put notes in. This is not a tool to document people's work. It's a tool to document a shared care plan. We actually have started calling it a shared support plan so that the clinicians don't get frightened or confused. It's a community support plan. It's not what the client's going to do, it's what we're going to do. What's Tory going to do? What's the mental health agency case coordinator going to do? We also have the magical ability to store documents here, IDs, eligibility letters, determination letters, pieces of paperwork that people spend hours and hours and hours and hours chasing in order to help coordinate benefits in the social service world. So we've done a lot in terms of process. We still do introductions because there are new faces there all the time. We can have meetings where there are 35, 40, 50 people around the table. So get a big table, aim high. Everybody must come prepared. It can really stall the conversation if somebody's like, I didn't get a chance to look yet, or I didn't look at the referrals. Like, then you must be here for the yogurt. Please try to do that. And folks are getting better slowly. Monday mornings are tough. We try to make sure that we don't spend all of our time talking about just one really hard case. And we're still following up in between meetings so that everybody doesn't have to wait for the next meeting to figure out what happened. So we're refining some of those processes. Some of the things that are challenging for folks, you think time on clients that aren't mine doesn't seem to diminish attendance. We're really struggling with poor audio because we're hosted in places that have not great business systems for communication. The IDN can make investments in that. Sorry, IDN, other region folk. We've done some tweaks to be able to coordinate the agenda. And here's the value conversation. So you've got these in your notes, and we can give them to you more clearly as well. But collaboration, networking, you get a more complete picture of the client. All those things that were outcomes or outcomes of not collaborating are improved. More efficient, less expensive. Client is less aggravated. Client is less frustrated. All of those things have value. So we've looked at, is this client less likely to be in the emergency room? Are they less likely to be hospitalized? Are they doing any of these things? Are they less homeless? I say less homeless as opposed to no longer homeless, because for many of these folks that are really complicated, homelessness is cyclical. So one of the things that we value is, are they going longer periods of time between being homeless? That's an improvement. If you only measure homeless or not homeless, you're not measuring what you need to measure to understand value and outcomes. We're increasing these linkages, getting people to the right place at the right time with the right providers. And we are actually seeing a lot more trust between partner agencies because they are meeting each other. What happens when you have trust among people who are exchanging resources and information? You have a more resilient network. It's 10 years of dissertation work for me, so I promise that that's actually statistically true. If people are trusting each other more and they're exchanging resources and information in an environment that has a higher degree of trust, you have a more resilient network. When you have all of this ridiculousness spinning around, 10-year mental health plan, MCOs changing, granted health advantage, who knows what's coming down the pike, you need some resilience to trust that your clients are going to be okay. So, value-based payments require valuing what matters to patients. Valuing what matters to patients requires knowing what matters to patients. It's a pretty simple, but it's a little profound. Knowing what matters to patients requires knowing patients. We can't know our patients in 9-minute increments. The second best thing is knowing the other people that know our patients. That's where your value comes from. Yeah. So we're happy to open it to questions. We're happy to talk about other cases. We've got folks in the room who have done this work fantastically.
You can offer to start it off. One of the things that people have a question about is, can you just tell me about one of these? How does this work? How does this really work for a client? So we actually have some folks that are from our integrated delivery network. Tammy has been nice enough to offer to maybe share a story, a narrative about a particular client that worked through the local CCT process, and what the benefit was, what the outcome was. So just a quick example, like how this works. Thank you, Tammy.
Oh, sure. So I'm Tammy. I work with the care team, and we've got a lot of good examples. One that comes to mind is a gentleman that came into the warming shelter about a year ago, and he had been kind of on our radar, which means somebody that we bump into out in the community, but really wasn't engaging in services, didn't have primary care, didn't have benefits, none of those things, and was actively using substances and was living out in the woods. So we kind of, as we saw him, we kind of just tried to check in and see how things were going, offer what we could, and probably about 6 months later he ended up in the hospital. We already sort of had a relationship built with him, so we were able to kind of check in with the hospital, give him a little bit of history, especially about where he was living out in the woods, some of the things that he might need, and then we could build more of a relationship and transferring to a different hospital so we could carry that communication over and build with that team there. And eventually he was discharged. It was kind of a hassle. Katie did beautiful work with him, and it was able to get him into a shelter, which this guy had absolutely no interest in going into a shelter, but because we knew them, we had a good communication and connection, so we could say, listen, these are good people, they're going to work with you, trust us. He was able to go, kind of got himself settled, and now he's working. He's in a MAT program. He's gone to see a primary care doctor, and this is night and day, the difference between this gentleman. And so when we get to see him, it's huge, and it's what makes this work meaningful and kind of just, it was a Christmas miracle, as you can see, from what he used to be to what he is now. And that is not because of one person, but because of all of us being able to work together and being able to just kind of communicate outside of our normal networks and just really just carry on conversation and what we know about this guy so that he could get the care and the life that he deserves. And now he's ready to move forward and take next steps and get into permanent housing.
Thanks, Annie.
How long can you stay in the shelter?
So for that particular shelter, they don't have a timeline. So as long as he can remain there, which is really the trick for people, is it can be too much. There's a lot of everybody who has mental health and substance use all under one roof tends not to work well for very long. So being able to support him while he's there is huge.
Right. Thanks. So we have about 15 minutes left. We're happy to answer questions. I do want to say that one of the biggest things I think that comes out of the community care team model is this ability to deconstruct myths. We talk about that a lot. Is that I make assumptions as a person every day about lots of things, but it's very, very easy for me to make assumptions about clients or patients based on my limited interaction with them. Why aren't they coming to their appointment? Why did they no-show 3 times? Why should I bother to make another appointment for them? I've called 10 times, they never call me back, they must not want any help, those sorts of things. So what teams like this allow us to do is to find out why, answer those questions. What's going on in this person's life that impacts their ability to interact with me successfully? And who are they actually connecting with? So it helps us to really understand where the client's level of need is. What's that hierarchy of needs? If I'm a mental health provider and I work by appointment in an office, but somebody is homeless and has no transportation, they're not going to come to see me first. They're probably going to connect with someone else in the community, and they're going to gradually become stable enough to connect with me consistently. So it's really important for us to talk around the table. It helps us deconstruct myths about patient behavior and client behavior, and it also helps us to deconstruct myths about each other and organizational myths, like this agency never does this, I refer here all the time and I never get anything back, I don't know what's going on over there, they're not doing what they said they were doing. And this brings us to the table to say, that's not what it's about. It's not about telling you. It's very easy for me to tell you what you should do based on what I think you're supposed to do. But it's a very different thing for you to come to the table and say, I actually can't. Either because I don't know how, or I don't have the resources, or it's not what I do. It's just not what we do. And our environment, our funding for services changes all the time, our demands for healthcare systems change all the time. So this is an ongoing conversation. What an agency did last year, they may have lost a grant to do something they were doing last year, and they're not actually able to do it this year. So what is the next best option? So these are moving conversations all the time, but bringing people to the table is the biggest piece, and it really helps us understand each other better, and to open up and realize that we're asking patients and clients to do this all the time. It's really not that scary when you're around a table of other care providers that you trust to go a little further beyond your comfort zone in some of these conversations and try to offer something different, connect somebody to someplace new, or introduce them to a new colleague, someone that you've just met, and be able to say to them, I know them. I've met them there. They're actually very nice. You can trust that when you go there, either I can come with you, or we can connect to make sure that you got there okay, and we can talk about the outcomes. So it's a really nice opportunity to understand each other better and feel supported in all of the really important work that we do every day, all of us. So any specific questions? Yeah, lots of questions. So why don't we start furthest back? There were some hands up in the back.
I have a comment and then a question. So my comment is, my son is 24, used to live on the seacoast, now lives in the beautiful Queen City with me, but one of his things, and he says this to me on a regular basis, but I even remember when he was a younger, teenager even, is he has so much anxiety just going to the mental health provider. And he had one guy when he was in high school that would pick him up at high school, take him for a ride, get him a nice coffee, and for the first year he never even knew the guy was a mental health therapist. And it was funny, he started on his IEP and he's like, oh Al, you're a therapist? Well, I like you, I'll keep you. And so I just think that sometimes, whether it's a peer support center or a coffee shop, that we really need to get to that point where we're thinking outside the box, that we don't have to offer people mental health services in a building. So that's my comment. I just think people need to really be creative about that. And then the other thing is that, my son actually this year was considered homeless. Luckily he had a car, so he was able to sleep in his car a lot, but he still wants to, the American dream, he wants to live on his own, but there's not really, one of his friends cashes his disability check and barely has $50 afterwards once he pays rent. And I think we need to, Maine has some, there's always other states that are doing things better, but I think we need to, all the IDNs need to look better at what we can do about really having some affordable housing options for this population, because I think, they deserve to have housing just like all of us, and that these crazy rents, when I see rents, I go, how can people afford that? We need to really look at some creative options on that too. So I don't know what you guys are doing on the seacoast, but I assume the IDMs all get together too, and that maybe we're addressing it as a state.
And so thank you for sharing your son's experience, because I think it's very much a lot of people's experience. And the challenge for the IDNs is that we are expressly prohibited from paying for housing, which is one of those "are you kidding me" moments. But what we are doing is having that conversation about what's the housing continuum look like, who can buy the building. We can help figure out the strategy and the staffing if we bring people together. So I think every region is having that discussion in different ways, shapes, and forms. But I encourage you, where do you live?
So we live in Manchester now, but we used to live on the seacoast, so it's like a whole different.
So you can have the IDNs are not a closed system.
No, and I work for I work for New Hampshire, but I'm actually funded by the IDN 3, so I'm in Nashua.
So there you go.
But it's just I think it's something that I think that's something, and I think even trying to get some of the people to bring their voice to the table when necessary too.
Yeah. So, and that is something we do. We don't bring clients to this table, but we've had little offshoot meetings with clients and smaller teams have come out of this as well. Yeah.
Do all of the IDNs have community care teams?
So I don't know if everybody heard the question, but the question is, do all the IDNs have community care teams? And the answer is no. One of the core strategies, though, of the IDN is to help to create multidisciplinary core teams, which includes a combination of behavioral health services and primary care services. And they're all challenged to, we're all challenged to identify projects within their community that were priorities for their community, their network, their neighborhood, their community. So the projects do look slightly different. Each one is its own demonstration project, so we're trying to find what works for specific areas, but then come to some ideas about what some of the best practices may be going forward for the state. But no, not every idea is doing this the same way.
I just wanted to, if you would clarify the feedback loops between the current care plan and the CCT case plan. What are the feedback loops?
What current care plan?
The-
Kevin and I have had this conversation for a year, so we're going to keep having this one.
Okay. What I'm trying to get to is, are the people doing the care plan different from the people who are developing the CCT case plan for the patient? And what are the feedback loops between
Yeah, I
them?
think you've identified really an important question, is that how many care plans does any one client need? So when we back up and look at the community care team, we have you could use the language shared support plan, because it's not about what the client needs to do, it's about what we need to do as organizations to support what the client wants to do. So most clients have multiple care plans at their individual clinicians if they're connected. So the way we transfer that knowledge to the community care team table is staff from those agencies who know that client. So the FQHC, the CMHC, the hospital, we don't touch, this table does, in this model, does not touch what the care plans are, if there is one. The folks who come to the table may go back, and what we try to encourage is that there's huddling and communication at this site, at the primary care office, that says, hey, guess what I learned? Does that information, does that knowledge need to inform the PCP's care plan? I don't worry about that, because the care plan that we're developing is the PCP is going to make an effort to schedule a client much sooner than what they told them yesterday they were going to do. So that doesn't have an impact on their care plan. So is that knowledge exchanged? Yes. Is the physical document exchanged? No. The knowledge exchange happens through staff interaction at the community care team via communication between the community care team meetings. They can certainly say, our goal is to help the client manage their diabetes. I don't care how you do it at the community care team, unless what you're saying is we really need help helping them be more mobile and more active, or they need help getting their medication, or. So that, if there is a need that comes out of the PCP's care plan that we can help brainstorm around, we'll do it, but we don't share that information as a whole. Other questions?
Thanks for the question.
I have two. One very quick one. What is the database that you use to track?
So we're using Allscripts Care Director. The rest of the state is using Collective Medical Technologies, a CMT product. So there are 1,000 different shared care plan tools. And prior to this, we were using Excel and it was working okay. So.
And my other question is a little more philosophical, way beyond what we can answer here, but I can't help myself, so I'm just going to put it out there. We talk about saving money, and presumably that also means time. And I totally believe in all of what we're doing and working very hard to do my part. But philosophically, when we talk about saving money, when we save money, what are we doing downstream or upstream or crosstown or whatever with that money we're saving? Can we begin now to be thinking about how we're going to invest that money to keep this thing going? And is there even any conversation about that going on?
I think there's always conversation about that. That's usually an after lunch conversation because it's a much bigger systems conversation, but it's a great question. When we say saving money, in real dollars, we're actually talking about reducing costs. So we get confused about reducing costs. Like, if I keep somebody out of the hospital, or if I get them out of the hospital more quickly because we don't do social boarding anymore, and I can find them housing, then the hospital experiences less debt.
So philosophically, it could benefit
Absolutely.
the whole.
Yes, it does, and I think it does. Does that free up, but is there also value in the trust that we create with the hospital so that the next time they do their community benefit assessment, they're going to hear what I'm asking for around housing a little bit, or what some other partner agency is asking for around peer support for mental health or for substance use disorders. So yes, you're right. I do think it's that trust that allows us to keep having those conversations. The dollar amounts are boggling. And who's at the table for the dollar amounts are not normally people that can talk about this without hives, frankly. So, but I like to think we're getting there. We're making it more accessible as a conversation with these sorts of kind of tools for folks. Other questions? I know that there was one here.
Well, I was just thinking now sustainability. But my question originally was, you invited people to come over and attend one of your meetings, and you also talked about consent and effectiveness and engagement. So the trust piece that we all hope to have, and that's what makes this work. Have you had struggles around that in the beginning? I know that some of our social service agencies and hospitals, the same thing we talked about earlier was, I don't know what you're doing, and I don't really want to deal with you because I don't know what you're doing. We do it better because we want to keep everybody here. We make the money and we do what we do. We don't want to share with you. So how did you sort of get back? Did you have experience with that, and how did you get past it?
So we did have a little bit of experience. I want to recognize that we're at time, so if folks want to jump out, you won't hurt my feelings much. So we did, you're right, it's a common thing. We did a little bit of a number of things. We went slow for some folks, and we had lots and lots and lots of conversations with folks. And we invited them to come watch and listen, and then bring questions back. But there was this other piece that I will say I think worked, and I don't know that it was intentional so much, but you never really want to talk a whole lot about something until you know if it's going to work. There was an element of mystery when we first got started. What's happening over there? Are you doing the same thing I'm doing? You better not be doing the same thing I'm doing. Well, why don't you come see if we're doing the same thing you're doing? Because I don't know what you're doing. We do have, there's a youth wraparound team, and then there's this, and there's an elder wrap team. And so we have folks now from liaisons almost. There are other little care teams out in the universe that we're still discovering. That I heard about you guys doing this. Well, come on over, check it out. Because our goal was to reduce the number of meetings everybody needed to be at. That's the tact we took. So if you come here, that might reduce the number of meetings you have to be at. And folks, by and large, have said, yeah, it's actually not bad. Or we can rearrange so it's not the same one person or two people that go to the other community meetings. We can mix it up a little bit. Folks get out of the office, we get collectively a little bit more knowledge shared, and then we come back around and say, how are you sharing it internally? Are you huddling? We don't have notes. What are you doing differently internally to be better at doing this internally than you were before you were coming here? So lots of conversations, invitations to attend, kind of one-on-one deconstruction of fears and misperceptions, and a little bit of mystery.
And if somebody comes to visit you, do they need to sign a consent?
They sign a confidentiality agreement, which just says, I know how to behave.
All right, great.